Hi, everyone. My name is Michael Stewart. I am here with the OI Foundation. I want to welcome everyone to tonight's talk. So this is going to be a BBDC research update, or the Brittle Bone Disorders Consortium update. This is going to be specifically about the NIH grant renewal and the future of OI research. I'm very excited today to introduce Dr. Reid Sutton, who, for those who have been to OIF events or have worked with the OIF before, they have definitely heard this name and seen him before. So Dr. Sutton is a geneticist at Baylor College of Medicine, but he's also a BBDC principal investigator and a member of the OIF Medical Advisory Council and our board of directors. So today we have a lot to talk about, and I'm very excited. I want to quickly, though, plug other OIF events that are happening in December. So actually, we have something coming up pretty soon. So if I can just go here. So I want to let everyone know on the call. So there's actually a upcoming OIF support group meeting. This is going to be on December 11th. This is going to be virtual, held over Zoom. And me or one of my colleagues are going to put the registration link into the chat soon. This is going to be from 8 to 9 p.m. and it's going to have different breakout sessions with a variety of different affinity groups. So women with OI, men with OI, young adults, so 18 to 30 years old, parents with children of OI, and the topic of aging overall. There's no age restrictions for that group in particular. So if you were interested in that event, please, we'd love to see you there. And so with that being said, I want to introduce Dr. Reid Sutton. So Dr. Sutton, in preparation for today's event, I was actually realizing we have done this talk roughly 3 years ago. I think it was in September 2022 or 2023, I want to say. And in that talk, we discussed a lot of different things that the BBDC was working on and how it relates to the work of the OIF overall and how it relates to OIF research overall. We have some exciting new developments since that talk. So we're excited to both review kind of what the BBDC is all about, as well as learn about these new developments and what this NIH grant renewal means for this program. So that being said, I'm going to stop sharing my screen, and Dr. Sutton, you are welcome to take it away.
Thank you, Michael, for the kind introduction, and thanks everybody for joining us this evening. Okay, does that look good, Michael?
You know what? That looks great. Thank you.
Okay, perfect. Thank you. Okay, well, welcome everyone. So as Michael said, I'm Reid Sutton. I'm going to be giving an update on the Brittle Bone Disease Consortium. So this is just a slide that is showing over on the y-axis turn my laser pointer on here. Over here on the right, the number of published research papers on osteogenesis imperfecta by year. So you can see things were like pretty consistent here up until kind of the mid 80s. And then there was the initial discovery of type 1 collagen genes as causing osteogenesis imperfecta. You see here the Professor Glorio's New England Journal of Medicine paper on the pamidronate treatment or bisphosphonate treatment for osteogenesis imperfecta. Roy, who it looks like is on the call, published the first recessive gene for OI, first new gene after this very large 40-year span here of between the type 1 collagen genes and the new recessive gene. And then you see that this was pretty consistent. In 2009, the OI Foundation funded the Linked Clinical Research Centers. So this was a precursor to the Brittle Bone Disease Consortium that I will be talking about this evening. And there were, this was again kind of a natural history study that was intended to tee us up for submitting an application to the National Institutes of Health. And you can see after that that the trajectory of publications really increased. And so I'm going to give credit primarily to the OI Foundation here in increasing the number of publications through research funding all the way back in 2009. This is the new network of consortia. So the Rare Disease Clinical Research Network was started by the National Center for Advancing Translational Research, used to be called the Office of Rare Diseases. And this started over 20 years ago with funding from the federal congressional budget that charged the NIH with focusing specifically on research on rare diseases. And so the way the National Institutes of Health, or NIH, decided to implement this, at least one way, was to fund consortia. So the idea was that for rare diseases, that any one institution or hospital or medical center in the United States would not have enough of these patients because obviously they're rare. And so they wanted to support the development of multi-site consortia for research in rare diseases. Again, this is a collaboration, as you can see over here on the left, between the National Institutes of Health, researchers and clinicians, and again, importantly, patient advocacy groups like the OI Foundation are all required members of each of these consortia. You can see here again the 2025 to 2030 group. These are 5-year grants. There are 21 consortia presently. The Brittle Bone Disease Consortium is shown right here in blue. These are the sites for the Brittle Bone Disease Consortium. You see that in yellow, these are clinical sites. And you see we kind of have a nice spread across the US, including and Canada as well, with the site at Montreal Shriners. I should say that, again, kind of as a plug, that the budget that we get from the National Institutes of Health for the grant would not allow us to support all of these sites, and the generosity of the community in donating to the OIF and allows the OIF to support these so that more people have access to enroll. The National Institutes of Health and National Center for Advancing Translational Research also funds a data management center. This is for all of the 21 rare disease consortia. This is at the University of Cincinnati, and I'll talk a bit more later about the work that they're doing. And then, of course, very important, the OI Foundation is the advocacy partner. So I'm going to kind of give you a little bit of history before I get into what's new for the most recent round of funding. So all of a requirement of the National Institutes of Health grant for all of the rare disease consortia is that one of the studies has to be a longitudinal or natural history study. We presently have just a little over 1,000 individuals who have enrolled in the longitudinal study so far. In the first cycle of funding, we also did a phase 1 clinical trial. So this is the earliest clinical trial in humans that is intended to assess safety and toxicity of a medication. And this was led by Sandesh Nagamani. And the medication that was used was an anti-TGF-beta antibody from Sanofi called fresolimumab. And this was selected because Roy Morello had shown in a mouse model that there was increased TGF-beta. And so in treating mice with the antibody against TGF-beta, led to clinical improvements in bone and other aspects, including lung. I will talk about another project later that was in this most recent cycle, which is looking at clear plastic aligners for correcting orthodontic malocclusion in severe forms of OI. And we've had a series of pilot and ancillary studies, including over the past 10 years, including urine biomarkers, quality of life studies, craniofacial imaging, pregnancy, pain and anxiety, and others that I will talk about. One of the requirements as well for all of these consortia is what's called a career enhancement core. This is very important, and the rationale for this is to ensure that physicians or scientists who are in training or early in their career are supported so that they can successfully enter rare disease research as a career and progress. The OI Foundation has been a very critical partner in this. One of the probably most successful things is a rare bone disease consortium prior to the meeting of the Society for Bone and Mineral Research, which has really grown over the years and again serves as an incubator for training individuals in rare disease research, especially OI and bone research. And then as well, maintaining a contact registry with the OI Foundation for research. So I'm just going to, again, go through a few of these studies that I had mentioned, including this phase 1 study of the medication brezilimumab, again, an anti-TGF-beta antibody. This is, again, just showing the individuals over on the right in the percent change in bone mineral density. This was a single dose. You can see that in this middle graph here, that individuals with type 4 OI, even with just a single dose, got a good increase in bone mineral density. However, the type 3 and type 8 OI individuals did not. These were all adults. And again, you can see similarly, again, in the second, the higher dose study, again, the individuals with type 4 OI got this kind of transient increase. They did subsequently decrease, but again, with a single dose, this is what you would expect. But again, the type 3 OIs did not seem to respond. This did prompt Sanofi. So that was a brittle bone disease study. Sanofi had loaned or provided the medication for free. Based on the results of this study, they did go on to develop actually a new anti-TGF-beta antibody. As you can see here, enrolled about 24 individuals. Unfortunately, they did not meet their primary endpoint, and so they elected not to continue with the study. That said, of course, people are probably well aware that there are other therapies in clinical trials, and some of those are shown here. I'm not going to go through all of those, but I do want to highlight that one of the missions that the Brittle Bone Disease Consortium is assigned by the National Institutes of Health is ensuring clinical trial readiness. And so we have partnered with and provided data to 3 different pharmaceutical companies who are working on new drug development. The reason that they're very interested is that, again, we have natural history or longitudinal data on 1,000 individuals. We collect a lot of different data on them, including things like fracture rates, bone mineral density, mobility, pain, whether they're on bisphosphonate or other therapies. And that's important to these companies because when they go to plan their clinical trials, these trials are very expensive, and they want to know how many individuals that they are going to need in a study to show efficacy. And so a number of the studies are using fracture rate. And so they want to understand, for, children 3 to 6 years old, how many fractures do they have on average annually? And if you're type 1 or type 3 or type 4, how does that differ? Because again, that allows them to do statistical calculations and modeling to know, again, how many people they need and if it's likely that their study would be successful. The longitudinal study, again, in this new cycle is ongoing. I will say more about that. I'm going to talk about the clear aligner study. I'm going to talk about the mental wellness study led by Eric Storch. Kathy Raggio, I think, has talked about the cardiopulmonary outcome study, so I won't review that. And I'll briefly mention the pregnancy study led by Dr. Deborah Krakow at UCLA. So just to start with a bit of background on the orthodontic trials. I do want to note that there are some intraoral dental and orthodontic photographs on the next few slides. So one of the things that was observed in the longitudinal study very early on, we did have a dental component of that, where there is a dental exam as part of the longitudinal study. And it was noted that there was what's called a class 3 malocclusion, and that's shown here, where the upper incisors or upper central teeth, which should normally kind of extend out over in front of the lower central incisors, either are kind of meeting on top or are behind. The other orthodontic challenge that again we noted in the severe forms of OI was what's called a lateral open bite. So you can see here on the side that the molars and premolars here are wide apart when biting down. And so as you might imagine, this is going to cause problems chewing. So Dr. Retravi, who was at the Montreal Shriners Hospital during this time, used clear plastic aligners in a couple of individuals with OI. And so you can see either here, the imaging study or the photographs down here at the bottom, where again, this is pre-treatment up here at the top, during treatment in the middle, and then after treatment at the bottom. That you can see now you are kind of correcting both the lateral open bite, where again, the molars are much closer together here in the back, and as well as the class 3 malocclusion, where now the upper central incisors are out in front of the lower ones. So because of this little pilot study that Jean-Marc did, a much larger study was initiated during this most recent funding cycle, assessing the safety and efficacy of a clear plastic aligner system. Individuals undergo 4 months of observation to assess whether the teeth are moving or not. And then after that 4 months of observation, undergo 12 months of intervention. And then at the end of that 12 months, are eligible to go into a 12-month extension study if the malocclusion is not fully corrected. There is a plan to enroll 57 children and adults with severe forms of OI. They need to have a significant malocclusion. This peer assessment rating scale, or PAR, score is essentially kind of assessing the touching of the teeth at the top and the bottom and the appropriateness of the alignment of the teeth. The primary outcome is the change in this PAR or peer assessment rating score, and there are a series of secondary outcomes. One of the more nifty ones is what's called masticatory gum. So this is a gum that when you take it out of the package is green. And as you chew it, there's citric acid in the gum that leaches out, becomes more neutral in pH when the citric acid leaches out, and then will turn a pink color. And so we have a protocol, again, for individuals chewing this gum, and then after a few minutes, assessing the degree of pinkness of that to assess the effectiveness of the chewing. This is a current status that Diane downloaded for me today. Just showing you again, we were not able to complete it during the most recent funding cycle, but do hope to continue this. And again, if you're eligible or if you're interested, the eligibility criteria are shown over on the right, and the sites are National Institutes of Health, UCLA, and Montreal. Next, I'm going to talk about the well-being study. I want to first mention the importance of the impact study that the OI Foundation and OIF in Europe did, assessing medical issues and concerns of individuals with OI. You can see over on the left here, the highest one was pain, reported by nearly 1,200 respondents, as well as fatigue, soft tissue issues, scoliosis. And you can see that fracture was kind of way down here on the list. And that aligns with what we were seeing in the natural history study. So Mercedes Rodriguez-Celine, when she was working with Peter Smith at Montreal Shriners, used the patient-reported outcomes data that we have been collecting as part of the natural history study. This included for children, the Pediatric Outcomes Data Collection Instrument, or POD-C, and then for adults, a standardized measure called SF-12. She also looked at other covariates, including the 6-minute walk test, pulmonary function tests, a physical therapist assessment, medication use, and others. And so what she saw is that, again, there were lots of different pain treatments, as shown over here on the right, with many of them used in combination in the what was reported in the BBDC longitudinal study. As well, you can see here by age group, so less than 10 years, 10 to 20, 20 to 40, and then finally greater than 40 years, where the yellow, blue, and green are the highest degree of pain interference. You can see that as individuals age, that this is a continuing issue or increasing issue with them. Specifically, this issue of pain interference, I'll talk more about later in a larger study. So based upon what we were seeing, we had proposed to look into this in more detail with a much larger number and more detailed patient-reported outcomes tools. This was led by Eric Storch, and there were 3 aims. The first was to engage various stakeholders, including the OI community, in semi-structured interviews to try to get an understanding of mental wellness and pain concerns. This was used to then select patient-reported outcomes tools that were incorporated into the longitudinal study. So individuals in the longitudinal study now, prior to their study visit, get an email pushed out to them from the Cincinnati Data Management Center to complete these prior to their research visit. So again, we have more data about this. And then finally, in-depth interviews of a subset of 300 individuals with OI. And again, this is just kind of showing you the different phases of the study. One of the things, again, that was seen is that there was in adults and children both. So the children were mostly parent reports. You can see increase in anxiety and pain interference compared to the general population. So the mean score for the general population for all of these is 50. And so anything above 50 is worse. Anything below 50 is better. And so you can see over here on the far right, this is a statistical calculation to say, is this number significantly different than the general population? And so again, you can see there were many things, but again, I'm highlighting particularly pain interference and anxiety. So what are these things? So pain interference is a measure of how much pain hinders a person's ability to participate in physical, mental, cognitive, emotional, recreational, and social activities. Pain anxiety is a person's tendency to feel pain or fear or anxiety in response to actual or potential pain. And so this is more of a future-oriented state of kind of excessive anxiety or arousal that's triggered by the anticipation of pain. And then the other thing that came out was something called pain catastrophizing, which is the tendency to kind of focus on pain events or the concern about having a pain event and is fostered by this kind of feeling of helplessness during pain. So this is all important, but obviously we want to understand with these issues of pain anxiety, pain interference, and pain catastrophizing, can we help individuals with OI? So there is this program called Mindful Self-Compassion. This has been used in a variety of situations related to pain, particularly things like chronic back pain or other sorts of things. The core tenets of mindful self-compassion are self-kindness, which is understanding towards oneself in instances of pain or failure. Common humanity, which is kind of understanding the pain or the experience as part of a larger human experience rather than as being isolating or separating from others. And then mindfulness, again, is holding thoughts and feelings in balance rather than over-identifying with particularly negative thoughts. Mindful self-compassion is based upon a positive psychology construct. It involves being open to suffering when that happens, that treating oneself with the same compassion that you would show other loved ones. And again, in various chronic pain studies has been shown to decrease pain interference. And so in anticipation of this most recent funding cycle, the BBDC performed a pilot study of mindful self-compassion. This was led by Marie Eve Robinson at Ottawa Children's Hospital and Children's Hospital of Eastern Ontario, and two of her students shown here. There were individuals in the group were type 1 and type 4 OI. They needed to have chronic pain for greater than 3 months. On a numeric pain rating scale, they had, again, a pain rating scale of 4.5, and the duration for many of them was the duration on average was 10 years, but again, you can see there's a wide range of duration of pain here. So over on the left, you see the study design. So 17 individuals were screened, 8 individuals were found to be eligible. They had a baseline assessment, which primarily included a series of patient-reported outcomes tools I'll talk about in a moment. They wore an actigraph watch. This is a watch that's used in medical research studies that can assess things like activity, mobility, and sleep. They then underwent the mindful self-compassion intervention that I'll talk about in just a moment. After the 8 weeks of the MSC intervention, they completed the intervention assessments and wore the actigraph watch again. And I'll show the data on the slides. The one individual who was actually much younger than everybody else in the study elected to withdraw from the study, and so only 7 of the 8 completed. You can, over on the right, you see that these are weekly sessions for a couple of hours. They were conducted online, and they were conducted by trained lay individuals. And there are a series of exercises that are shown here. I'm not going to read through all of those, but it's things like giving and receiving compassion, breathing meditation, self-compassion and soothing, and other sorts of things during this 8-week intervention. The assessments that were done before and after, again, a series of standardized patient-reported outcomes tools were employed. And again, I won't read through all of those, but again, they were selected to get a detailed assessment of kind of how this intervention did. This is just showing results of the individual satisfaction and attendance at the sessions. You can see that 86% of individuals attended 6 or more of the 8 sessions. 90% of them completed all of those surveys I showed on the previous slide, and they all did great at wearing the actigraph watch with full compliance there. Over on the right here, you see the graphs with questions about, was 2 hours the right amount of time? Was once a week the right frequency? Did they like the virtual format down here on the bottom? And then the difficulty of the material. And you can see overall, this was generally viewed very positively, with most participants kind of agreeing or strongly agreeing with all of those items. Oops, sorry. And then these are pre and post-treatment results. So again, this was a small number of individuals. It was not designed or powered to show a difference. But over here in this graph, this is looking at pain interference, difficulties in emotional regulation, and experiential avoidance. And you can see that pre-treatment, shown in blue, that there are lower scores at the end of the study overall for each of these domains. And again, lower on this is better. And then again, these other questionnaires assessing pain acceptance and self-compassion, where higher numbers are better. You can see, again, at baseline in blue compared to the end of the study in orange, that again, there was increase in pain acceptance and in self-compassion at the end of the 8 weeks. And then just a brief word on the pregnancy study. So one of the things that came out in an initial survey was what seems to be an increased risk of bleeding in women with OI during delivery, as well as increased cesarean section rate and increased blood transfusions. And so this is an ongoing study, again, led by Deborah Krakow at UCLA, that's continuing recruitment. So if you're interested, again, here is the email link to participate. And then again, I certainly want to give a big shout out to the OI Foundation-led community engagement as part of the grant. This includes the recruitment and support for the Brittle Bone Disease Consortium research, the teleecho series that are available online, the OIF podcasts, as well as the adult toolkit and various other toolkits that have been developed. So I'm now going to move on to talk about kind of what we are proposing in our third and final cycle of the study. So we received word a couple of months ago that we were refunded for the Brittle Bone Disease Consortium. The National Institutes of Health only allows these rare disease centers to have 3 funding cycles. And so this will be our final cycle. So you can see here from NIH Reporter, these are the projects that we were proposed. And again, this is led by Brendan Lee. You can see again here, Project 1, the longitudinal study, the mindful self-compassion study that I'll talk about, and then an imaging study that will be led by Bettina Willey and Frank Rauch. And then again, continuing the career enhancement core, which again is intended to recruit young investigators into OI research. So in this final cycle of funding, we really focused on the legacy. So we know we're almost certainly not going to get any another renewal out of this. And so one of the things that we, again, are really focused on is how do we create a large database or data set that is going to be valuable going forward, even after the BBDC is no longer part of the Rare Disease Clinical Research Network. As I had mentioned earlier, so the National Center for Advancing Translational Research funds this Data Management and Coordinating Center at University of Cincinnati. And as part of that, the data is all stored in the cloud securely. There is the ability to store clinical data as well as genomic data and radiographic data. So one of the projects that we plan to complete at the end of this next 5-year cycle is to have central reading of over 4,000 X-rays, mainly spine and scoliosis X-rays. This is being done by Leanne Ward and her group at Children's Hospital of Eastern Ontario in Ottawa. These X-rays are uploaded from the individual research sites through a process called Umbra, and then are downloaded by Dr. Ward's group. And again, these are going to be stored centrally and essentially available in perpetuity. Similarly, the REDCap database that the Data Management Center uses, again, will be available at this point indefinitely. We are really focused on getting 7 years of longitudinal study data on all participants to have a uniform and robust data set. And then finally, we're in the process of whole genome sequencing. Again, the NCATS at NIH funds a tool called Cavativa, which is genomic data storage and analysis tool. One of my colleagues here, Hongshin Dai, has started working on this and has been uploading the genome sequencing FASTQ files that we are processing, and then that again will be available in perpetuity. Right now, we're really focused on getting reports back to individuals. So we are in the process of starting to develop these research reports focused on genes known to be associated with OI. Those will be provided back to the individual principal investigators and research teams at each of the sites. that they can then provide to the participants. I'll talk about the mindful self-compassion therapeutic intervention trial, and then imaging study that I had mentioned earlier. Again, career enhancement core will continue. So the mindful self-compassion study. So we will enroll 103 adults with OI in this mindful self-compassion. They will be randomized either to relaxation training or the 8-week mindful self-compassion. We will again use a variety of these patient-reported outcomes tools to assess broadly things like pain interference, well-being, and function, characterize the psychological mechanisms associated. This has not been done, so the way this works in chronic pain is not understood. And so we actually are going to kind of use and kind of employ an iterative strategy as shown over on the right to try to understand how that works. And importantly, again, if this works, this is something, again, that is led by trained individuals from the patient population. And so this could potentially be employed by OI Foundation or OI community, where they could, again, kind of have trained individuals that could conduct the mindful self-compassion to address pain anxiety and pain interference. And this is just all of us at the in-person meeting in 2003. I couldn't find a photo from 2004. Apologies, but we're all very happy. I want to thank all of the physicians and scientists shown over on the right that make this possible. And then, of course, OI Foundation, as well as funding from multiple institutes at the NIH that you see here. I've mentioned National Center for Advancing Translational Sciences, but also National Institutes of Arthritis and Musculoskeletal Diseases. National Human Genome Research Institute is new to this funding cycle and funding the BBDC, Eunice Kennedy Shriver, Child Health and Human Development, and the National Institute of Dental and Craniofacial Research. But most importantly, I want to thank you, the OI community, and the OI Foundation for your interest in research and participation. So I will conclude there, and I'm happy to take any questions.
Dr. Sutton, thank you so much for that presentation and for all the work you do. It is very evident just how big of a project this is and all of the moving parts. It is always so impressive to get these updates and kind of just blown away by you and all the work that you and your team do. So I've got a couple questions I see a couple questions in the chat. If anybody has any questions for Dr. Sutton, feel free to write them into the chat. We should have enough time to answer a bunch here today. So my first thing I want to ask you is, so you covered a lot just now. In your opinion, and it could be a study, it could be a part of a study, or like a overall something that's not quite directly one study related. Is there something that is like the most transformative or important achievement of the BBDC so far?
Yeah, I guess I think that, well, so first off, I guess I would say I think the biggest achievement is essentially in creating the network. Again, that was really initiated by the OI Foundation, founding the Link Clinical Research Centers prior to the funding from NIH for the BBDC, because again, for all rare disorders, including OI, most centers don't have enough patients to really kind of conduct these robust studies on their own. And so really the most important part, I think, is establishing a network, getting everybody to work together and collaborate to really move things forward.
Mm-hmm. That's great to hear. I mean, it's definitely something that, working at the OI Foundation, going to scientific meetings, going to conferences, you see that camaraderie and professional community amongst the MAC members like yourself, amongst the other researchers and people affiliated with the BBDC. It really is fantastic to see. Um, Something else I wanted to ask about is, so you brought up about the NIH renewal process. Could you kind of briefly explain a little bit more what that was like, and roughly how long did that process take?
It was a lot of work.
Yeah, yeah, yeah.
So yeah, so basically so these are what's called competing renewals, which means there are people that submit new proposals and then people that have existing networks that
Mhm.
are submitting for renewal. They're all reviewed together similarly. So we don't necessarily, the old centers like the BBDC don't necessarily get priority over everybody else. We have to really show that we've been, making achievements and meeting the milestones as National Institutes of Health would expect. This is a peer-reviewed process. So it's, not some bureaucrat at NIH that's kind of reviewing these, that these are physicians or scientists kind of in the field that are really critically reviewing this. And so again, it's not kind of a rubber stamp sort of thing.
Gotcha.
It's an enormous amount of work. So we proposed the three studies, the imaging study, the mindful self-compassion study, and the longitudinal study. Each of those is 12 pages long. And then there are a variety of other sections that are like human subjects and the career enhancement core and other things. So the whole thing usually comes out like a couple of hundred pages. If you add in all the things that
Yeah.
the administrator has to put in, like all of the bio sketches and other things of each of the participants and information about each of the sites, it comes out probably about 800 pages or so. So
Right.
it's a lot of work.
Yeah, it's a very large book. Yeah, because I mean, I'm thinking back to the slide you showed with the honeycomb of all the different consortium. All of those don't necessarily get their third round. Um, and so yeah, we're very thankful for all your work. Um, so another question I had was, so with this new funding cycle, you talked about some of the things looking forward. Um, or is there anything that you're specifically or especially excited about moving forward with this next phase?
Yeah, I think really the most exciting thing is, again, this idea of kind of creating a legacy that I think that, the mindful self-compassion I think is very important, that if that intervention works, again, will help to address these kind of pain, and mental wellness issues in individuals with OI that, again, you saw in the impact study was number one, right? By a long shot, right? And so, I think that's one of the things we've always really tried to be sensitive to is listening to the community and not saying, here's what, you know, we think is important, is really kind of trying to listen to the community and say, what does the community think is important? And like try to address that in the research of the BBDC.
Mhm.
Um, the imaging study, again, I think is going to be important. But again, I think the most important thing is that, again, there is going to be this very large data set that's going to be essentially publicly available to researchers. I should note that, again, this is a secure database. It's only available to researchers. There's no individually identifiable information in it. But again, if someone, you know, even after the study is over, says, I want, genomic sequencing data and, bone mineral density or something else, fracture rate, to try to understand why some people with OI type 1 fracture rarely and some people with OI type 1 fracture a lot more. That again, that's going to be available to them. It's a living resource.
Yeah. That actually kind of segues into some of the next questions I want to ask. So one, so I see some questions in the chat here. One from Ted is asking, so he's talking specifically about the malocclusion study with the clear aligners. So you showed some pictures. This might be too technical of a question, but you showed some pictures of clear aligners used with rubber bands. Do you know if the study uh, was looking at the combination of clear aligners and rubber bands, or
Yes, they
just?
usually need those little posts with the
Mhm.
rubber bands for the lateral open bite, so where the molars don't meet. That's kind of what that's primarily addressing, right?
Okay. Um, and the other question I see here that actually I was thinking the same thing as you were talking just now was about so the data from the longitudinal study is stored on the cloud. It is not publicly available. Um, so it's available to researchers. So are we talking about like just academic institutions? Is this open to like I'm thinking like, the PhD student writing their dissertation? Is it open to pharma companies that want to use it, so
Yeah.
like industry
Yes,
players?
it's open to all of those
Okay.
groups. And again, because the pharma companies, they're the ones that are really going to do the drug trial. So as I mentioned, we did this kind of very small phase 1 drug trial, but what are called phase 3 drug trials, which are the kind of pivotal trials that are done to really assess efficacy, to then submit that data to the Food and Drug Administration for approval of a new medication. Those are really expensive, and they are not something that the National Institutes of Health generally funds, and they're not something, again, that usually an advocacy group or someone else would really be able to do. It really takes kind of the public sector and biopharma companies to really have the money to be able to do that. And so again, this is again a critical mission, is ensuring clinical trial readiness, because we can't do that, but we want to ensure that biopharma companies again are going to have a leg up to be successful and to understand what they need to do. It also, I think, encourages them to get into the space. It's very common that for rare diseases that biopharma companies maybe are wary to get into the space because they are unsure what it is they're going to need to show. Um, I'll give you an example for another rare bone disease, achondroplasia, the most common form of dwarfism that people are Game of Thrones fans, Peter Dinklage has. The biopharma company that got the first drug approved for achondroplasia, they actually had to do their own natural history study because there was no natural history study available. And so the fact of having a natural history study again is viewed very positively by a biopharma company because they don't have to spend money doing that we've already done that.
Yeah. And yeah, I keep thinking about I think you mentioned there are three current clinical studies happening right now with treatments developed by the BBDC. I keep thinking about it in terms of like, I know I was using like a racehorse analogy the other day to someone of like, this is sort of like raising, you don't know which horse is going to be like a racehorse versus just like a normal horse. And the pharma companies may bring them across the finish line, but like the BBDC is like raising them as yeah, baby horses. But yeah, I see Tracy has her hand up. Tracy.
I do. Thanks so much, Reid. That was an awesome update. I just wanted to quickly ask you about the genomic testing. I think we're the only consortium that is doing that, correct? I mean, and that is like an amazing um, research. I don't even know what the word is, but I mean, it's really fantastic.
Correct. Yes. So yes, that's right. So we're the first actually, I think, to use that cavativa, because we actually had the data management center had a webinar for all of the principal investigators last week, I think, on cavativa, and they were very interested to talk to us, and particularly again like Hong Jin Dai at our site, who's been doing the analysis again in the cavativa system in the cloud. But yes, so this is the only consortia that's going to have essentially genome sequencing. Again, we're aiming for everybody in the longitudinal study. We're this is a lot of work. It's not something that's going to happen overnight, but we're committed, but, again, at the end of the 5 years to having that as a resource.
Fantastic.
Really impressive. That sort of answered actually my next question, which was going to be about like what changes are being planned. And I think doing a full genome of every longitudinal study member participant would be incredible. So I've got one final question I have prepared for you, and if we have any other questions from the chat, please put them in. So mine was actually so for this grant renewal, it was a few $1 million over a few years. If you had unlimited resources and money, so also financial resources, manpower resources, what would be some of your research priorities that you would want to look into with this data we have?
Yeah, I think that, I guess I think that, one of the, I mean, there are always budgetary constraints. So I'll give you an example that, unfortunately, the funding for the mindful self-compassion study was not sufficient to do the actigraph watches. We had hoped to do that, but we didn't get enough funding to do that. If anybody's got a few $1,000s laying around, they want to send our way, we'll add the actigraph back in. But we, I think, there are those sorts of things that happen. I think the biggest one though is it really, honestly, more than money, really like a manpower issue, right? We've generated such a large amount of data, and again, generating the genome data and the radiographic X-ray database, we're so busy generating all the data, we don't really have sufficient time to analyze it in ways that we would want to. But again, that's why we're really focused on kind of in this last cycle data generation, because that's the most money expensive part, the time part, right? Once the data is generated, then essentially it's existing. It's mainly just an individual's time.
Yeah, definitely. Yeah, just pure manpower. I see one final question I see in the chat was somebody's asking about, could you just speak a little bit more about those 3 pharma trials? And could you just talk about them a little bit more for someone who has not heard of them before?
Right. So I think the one that's furthest along is the Mereo and Ultragenyx trial of a medication called setrusumab. So this is another antibody. It is not an antibody against TGF beta that I'd mentioned earlier. It's an antibody against something called sclerostin that regulates bone development. As an example, so again, they have used that data again to model their clinical trial development. There are other drug companies again that we have provided data to. We actually have had a couple of drug companies even that are very early in development that have asked for like biospecimens. We have a limited number of biospecimens on people. We've not given data or biospecimens to everybody, and notably the biospecimens, because again, those are a precious resource for us. That the companies did not seem to have a very robust assay. That the preliminary data they showed us did not look very good. So we kind of nicely told them, we want to help you, but you need to show us an assay that looks better, because what you're showing us doesn't really look great. So
Gotcha.
yeah, we're committed to continuing that.
I think that's partnership and how this is a tool not just for OI clinicians immediately, but also this research field in a larger sense is really important. We feel incredibly grateful. So Dr. Sutton, it's 8 p.m. here on the East Coast. I want to thank you for your time with us here today. On behalf of the entire OI Foundation, thank you so much for your talk today, for your dedication to OI and the OI community. Dr. Sutton, thank you so much.
Yep. Thank you. Thanks to the OI Foundation for all their hard work, all the folks that are on the call. And again, thanks to the community for joining tonight and your support.
Great. Thank you so much. To anyone still on the call with any questions, feel free to email the OI Foundation at bonelink@oif.org or respond to any of the emails you get, and we'll get back to you as soon as we can. Thank you all so much, and everyone have a good evening.